Hi, I am Shourdip Dotto, MBBS and MS in Gynecology and Obstetrics. I am now Senior Resident of Neelottam Sarkar Medical College, and today I will discuss a complication, that is rectus sheath hematoma, and we will discuss this rectus sheath hematoma in scenario based approach. Let us take two scenarios. In first scenario, patient is para 2+0, undergone LUCS 20 hours ago with complaint of, and now she is complaining the acute pain abdomen. The indication of LUCS was abruption followed by fetal distress. On examination, the patient is conscious at cooperative, pulse rate is 128 per minute, that is tachycardia, blood pressure is 104/70 mm/Hg, and pallor is mild to moderate. Per abdomen uterus is contracted, and around 20 weeks a firm tender 5 × 5 cm mass felt on anterior abdominal wall between stitch line and umbilicus. What is the diagnosis and management? Let us take second scenario. A 30 years old female, para 1+0, undergone LUCS on emergency basis due to severe fetal distress, and she is known case of heart disease, and that is repaired mitral valve with metallic prosthesis. On medication, 8 hours after LUCS, patient complaining severe pain abdomen with drowsiness. On examination, patient is conscious but drowsy, pulse rate is 146 per minute, blood pressure is 80/54 mm/Hg, pallor is severe, per abdomen is 8 × 12 cm firm tender mass below umbilicus, and blood oozing from stitch line. The uterus is difficult to palpate. Then what will be your diagnosis and management? Okay, let's discuss some basic anatomy of anterior abdominal wall. Look at this picture and we will discuss anterior abdominal wall. Now look, this picture is the cross section of anterior abdominal wall above umbilicus, and this picture is anterior abdominal wall cross section below umbilicus. Now what is the difference? What is the difference? Now look, here we have three muscles, that is external oblique, internal oblique and transversalis muscle, and that is fascia transversalis. So external oblique, internal oblique, transverse abdominis, fascia transversalis, and this is rectus muscle, and this is anterior rectus sheath. This is posterior rectus sheath, this is I have told, this is fascia transversalis, and this is peritoneum. Okay. So let us see here again, this is umbilicus, and now we will discuss the anterior abdominal wall below the umbilicus. Here we can see we have this rectus muscle, external oblique, internal oblique, that is transverse abdominis, and this is fascia transversalis. Okay. Now look, the deficient thing below the umbilicus, that is this layer, this is posterior rectus sheath, and we have two vessels just below the rectus muscle and above the posterior wall of rectus sheath. These two vessels are inferior epigastric artery and vein. Okay. Here also these two vessels, these are inferior epigastric artery and vein. So, let us discuss that we have two arteries, both are culprit arteries for rectus sheath hematoma. First one is inferior epigastric artery and another is superior epigastric artery. The origin of inferior epigastric artery is external iliac artery and it is from external thoracic artery. Okay. Now, the thing is that this inferior epigastric artery, it causes rectus sheath hematoma below umbilicus, and it is responsible for rectus sheath hematoma above umbilicus. But the thing to be noted here that below umbilicus there is no posterior wall of rectus sheath. So, the bleeding is more. Okay. The bleeding is more, and often the rectus sheath hematoma below the umbilicus, actually it is below the arcuate line. Below the arcuate line, this is the arcuate line. Okay. This is arcuate line. Okay. This inferior epigastric artery causing the rectus sheath hematoma often crosses midline. So, it forms bilobed rectus sheath hematoma, that is bilobed rectus sheath hematoma. Now, if we see that now this is a part of rectus muscle, okay, and this is rectus sheath, and inferior epigastric artery lies in between these things very loosely, and it provides perforator in rectus muscle. So, if any trauma or contraction that is preferably asymmetrical contraction over rectus muscle, there is chances that these vessels get torn easily and bleed. These are perforator. Okay. Perforators get torn and bleed. Okay. Let's see some information about etiology. The etiologies are: 1. Spontaneous rectus sheath hematoma, and another is following any surgery over abdomen. The spontaneous rectus sheath hematoma have some backgrounds like heavy weight lifting, heavy vomiting, and heavy cough, sneeze with coagulation defect. A history of anticoagulant, history of steroid, CKD, and any kidney failure patient. Following any surgery of abdomen, in spontaneous RSH also happens in pregnant women. Okay. Following any surgery of abdomen, some predisposition there like coagulation defect, and of course the main cause is improper hemostasis. These things make tear of inferior epigastric vessels, superior epigastric vessels, and tear of rectus muscle. Okay, and there is chances of tear of anastomosis between these two, but as it is microanastomosis, no major bleeder get torn, so chances is low. Okay. So the type of rectus sheath hematoma. Rectus sheath hematoma, basis on severity, it has three types: type 1, type 2 and type 3. The type 1 is purely intramuscular hematoma. It is same plus blood between muscle and fossa transversalis. This is bleeding between rectus muscle and fossa transversalis plus minus hemoperitoneum. Now it is usually unilateral, but may be bilateral. It is generally bilateral. Here PCB drop is minimal or ignorable. The PCB drop is noticed here, and here the PCB drop is significant. The hematocrit drop or PCB drop is significant here, and here we need no hospitalization, but here hospitalization needed for observation, and here hospitalization needed plus minus intervention. We should know few things like right sided rectus sheath hematoma is more common than left sided, and the female is to male predisposition is around 3:1, and black people has low chances of rectus sheath hematoma, and leukemia is cause of many spontaneous rectus sheath hematoma. Okay. Now, what is the prognosis? Now, the prognosis is good in maximum time, and in maximum cases the conservative management is enough, but though it is in most cases it is self limiting, but sometime even small hematoma can cause hypotension and shock, even death. So, patients should be monitored, and always we need to monitor the vitals and the morbidity. The morbidity is mainly due to unnecessary exploratory laparotomy and delay in fluid resuscitation. So, mortality is around 4% in normal people, and in spontaneous rectus sheath hematoma, and 18% in iatrogenic, following any surgery, and 25% if patient is on anticoagulant. Morbidity is mainly due to one, unnecessary exploratory laparotomy, 2, delay in fluid resuscitation. So, come to the management. Management has two parts. One, diagnosis. In diagnosis, it mostly the suspicion is clinical. The suspicion is clinical, but when there is no modalities like USG CT scan, 17 to 40% rectus sheath hematoma could only be diagnosed clinically. So, the diagnosis is typical clinical history, that is pain or any history of predisposing pain abdomen factors, any history of abdominal surgery, or tachycardia plus minus hypotension plus minus pallor and abdominal superficial tender is plus minus mass. And what is other modalities of diagnosis? We can send some blood investigations like hemoglobin, coagulation profile, that is PTA, PDT, INR, CBC, LFT, RFT, and radiological investigations. There are USG. USG is good screening method and also for evaluation and to check whether the hematoma is expanding. The CT is 100% sensitive and 100% specific up to 5 days of onset of hematoma. MRI is better in chronic rectus sheath hematoma to distinguish between any other abdominal mass. But USG is most commonly used. Now, what is the treatment? In most cases, the treatment is conservative if patient is hemodynamically stable and the hematoma is not expanding, the symptom is minimal. But even small hematoma, rectus sheath hematoma, can cause hypotension plus minus shock. So, we should be very careful regarding the monitoring of vitals and the patient's urine output and whether the mass is getting larger or not. So, what do I mean by conservative management? It is like rest, analgesic, antibiotics, ice pack, compression and fluid. 7 is anticoagulant reversal. 8 is blood product transfusion. Okay. Now, the patient should be in rest, but patient should be mobilized so that there is no chances, there is because there is risks of DVT. So, patient should be mobilized. So, patient should be mobilized and analgesics, there are many analgesics we can prefer, even opioid based. like tramadol and buval or patch, antibiotics like IV antibiotics, ceftriaxone, piperacillin, tazobactam, that is 4.5 gram TDS or it is 1 gram BD, ice pack, compression fluid, anticoagulant reversal. It includes things like vitamin K injection, that is known as phytonadione. There are many routes of vitamin K injection: IV, subcutaneous, oral, IM. IV dose is 1 to 10 milligram at 1 milligram per minute rate. There are chances of anaphylactoid reaction. The IM is 1 to 10 milligram, preferably 5 milligram. Subcutaneous is unpredictable and oral is slow to act. We can use fresh frozen plasma. We can use it with Lasix if overloaded, and fresh frozen plasma can supply coagulant factors for 8 hours, and it should be transfused 15 ml per kg. Another is protamine, that is antagonist of heparin. It acts against unfractionated heparin, that is known as UFH, and the dose is 1 milligram per 100 UFH, 100 unit UFH. Now, it will not work if UFH bolus dose given in last 2 hours. So, the conservative management, what will be the hospital stay? The hospital stay is 10 days minimum, and it has 85.7% success rate as per Bina et al. The study was done at 2000. What is the other method? The other method is invasive method. Invasive method is transcatheter embolization of epigastric artery. And second is exploratory laparotomy. Here what we do? We do evacuation of hematoma to ligation of bleeding vessels. 3. Place a drain above and below the rectus muscle. But when we will do that? One, the patient is hemodynamically unstable. 2, type 3 rectus sheath hematoma, type 2 rectus sheath hematoma with hemodynamical unstable. 4, along with hemoperitoneum. 6, any active bleeder on USG or colored Doppler. Sorry, it is 5. And 6, any expanding hematoma. So, how we will prevent? One, we need to secure hemostasis. 2, if any anticoagulant is getting to stop coagulant before OT3. Stop vigorous handling of rectus muscle for avoid overstretching of rectus sheath. These are some way to prevent rectus sheath hematoma in case of laparoscopy. Okay, enough for today. We will discuss our next topic in next day. Good night.